everyone. My name is Dóra Fedorcsák, and allow me to share some insights into my PhD thesis titled Optimizing Techniques and Outcomes in Implant-Based Breast Reconstruction. Breast cancer is the most common malignancy among women worldwide. More than half of breast cancer patients receive radiotherapy at some point during their treatment, and up to 60% of mastectomy patients receive breast reconstruction, most of which are implant-based. As the use of biologic and synthetic meshes to support implant-based breast reconstruction becomes increasingly widespread, it is critical to evaluate their outcomes in the irradiated population. Our meta-analysis of irradiated patients undergoing implant-based breast reconstruction shows that synthetic meshes are comparable in efficacy and safety to biologic meshes. Our results support the use of synthetic meshes as a clinically viable alternative to biologic meshes in these complex reconstructive scenarios. Further studies are needed to support these outcomes, and policymakers should consider promoting the use of synthetic meshes as a cost-effective alternative to biological meshes. Allow me to introduce myself. I'm a sixth-year medical student and a first-year MD PhD student. Together with my supervisors, our vision is to provide the best possible surgical care to breast cancer patients, and our mission is to find which adjunctive materials can help achieve a better surgical and aesthetic outcome. We have started two projects in last fall, the first one in September and the second in November. Allow me to introduce the first project, which is investigating the effect of adjunctive materials on implant-based breast reconstruction outcomes in irradiated patients. In 2022, 2.3 million patients were affected by breast cancer worldwide, and as I have mentioned, up to 60% of these patients undergo breast reconstruction after their mastectomies. Unfortunately, for patients who received radiotherapy, there is an increased risk of capsular contracture, implant loss, or infection. Reconstruction failure can be up to 40% compared to only 10% in irradiated patients versus non-irradiated patients. The use of adjunctive materials like biological and synthetic meshes supporting the implant can help achieve a better surgical outcome and less complications. Our aim is to determine which material is most useful in patients who received radiotherapy. We are using the PICO framework with the population of patients who underwent implant-based breast reconstruction and received radiotherapy, and we are comparing the use of synthetic meshes to biological meshes, and we are looking at surgical outcomes such as skin necrosis, capsular contracture, or implant loss. We hypothesize that the use of synthetic meshes as an alternative to biologic meshes offers similar outcomes. We have conducted our preliminary research in 3 databases with the search key consisting of 2 domains, the first one focusing on breast reconstruction and the second one on the use of biologic or synthetic meshes. We have started with over 12,000 articles, and we have narrowed it down to 47 and added 4 more by citation chasing. Allow me to introduce our primary outcomes. We can see here a forest plots of pool proportion rates with subgroups of biological mesh and synthetic mesh use. The pool proportion rates of total complication means the rate of patients who experienced at least one surgical complication after their reconstructive procedures. We can see here that for both the biologic and synthetic mesh subgroup, the percentages were 33% and 30%, meaning that similarly around 1/3 of patients were affected by at least one postoperative complication, and the p-value for subgroup differences was not statistically significant. To further explore these outcomes, we have conducted a multivariate analysis accounting for variables such as the placement of the implant, whether it is above or below the muscle, and radiotherapy timing, whether the patient received radiotherapy before or after their reconstructive procedure. We can see here on these tables that regarding implant loss, radiotherapy timing showed statistical significance, with the odds ratios showing that preoperative radiotherapy might pose a higher risk for implant loss. Regarding the placement of the implant, both implant loss and capsular contracture, which is one of the most common complications in irradiated breast reconstructions, was statistically significant in both of these outcomes, with the odds ratios suggesting that subpectoral implant placement can pose a higher risk for these complications. In conclusion, we found no statistical significance when looking at only biological and synthetic meshes alone, but we found on multivariate analysis that radiotherapy timing and implant placement is statistically significant regarding these outcomes. Our study helps inform decision-making about surgical technique and supports an individualized approach considering patient and surgical factors, but further studies are needed. We have finished writing the manuscript, and we have submitted our manuscript to the Journal of Plastic and Reconstructive Surgery yesterday, so we are hoping to hear back from them. Regarding my second topic, it's investigating the efficacy and safety of negative pressure wound therapy in prosthetic breast reconstruction. In 2022, around 150,000 breast reconstructive procedures were performed in the US, and as I have mentioned before, around 80% of them are implant-based. The infection rates of these procedures can range from 2.5 to almost 25%, which can lead to implant removal, but also delays in the administration of radiotherapy and chemotherapy. The use of a negative pressure wound therapy device, which is a vacuum device, it can help with the reduction of stromal formation after these procedures, but most importantly, it decreases bacterial colonization. Utilizing negative pressure wound therapy, in the case of infected implants, where a redo operation was needed, the time to final reconstruction was reduced from 220 days to only 70 days in some studies, which can also help in reducing the healthcare costs of these procedures. Our aim is to find the most effective technique to minimize complications in implant-based breast reconstruction. We are again using the PICO framework with the population of patients undergoing implant-based breast reconstruction, and we are comparing the use of negative pressure wound therapy both preventively and in the case of infected implants, and we're comparing them to standard wound care. We are again looking at postoperative complications and salvage success rates. We hypothesize that the use of negative pressure wound therapy in breast reconstruction can help achieve accelerated wound healing and better salvage success rates. The clinical implication would be the more widespread use of negative pressure wound therapy in breast reconstruction procedures. We have conducted a preliminary search with 2 search key domains, the first one focusing on breast reconstruction, the second domain focusing on negative pressure wound therapy. This project has passed the feasibility check, but we are currently in the beginning stages of this second project. In summary, we have started working on 2 projects to investigate the efficacy of adjunctive materials in implant-based breast reconstruction and also the use of negative pressure wound therapy. We have submitted the first article this August, and we are planning to submit the next article in the beginning of next year. I would like to end my presentation with a quote from Mahatma Gandhi: "Live as if you were to die tomorrow, and learn as if you were to live forever." Thank you for your attention.
Thank you very much. It was very interesting again presentation. I am not plastic surgeon, but I have just one question. Do you use mesh in the reconstruction after the breast cancer operation? If I could remember, sometimes use mesh.
Well, currently, biologic meshes are not really commonly used if we're talking about Hungary, you mean?
Uh-huh.
Currently, synthetic meshes are being introduced, and it's a more cost-effective alternative. It's like around 1/3 of the price compared to biological meshes. That's why this study is clinically relevant. And there has been a trial period at the National Institute of Oncology a few years ago. And right now, again, synthetic meshes are being reintroduced, and they are not experimenting, but trying again the use of synthetic meshes in this breast reconstructive procedure. So in Hungary, currently, we are only starting out with this practice, but around the world, in more Western countries, it is more widely used.
Thank you.